Good evening. We're here with Dr. William A. Yasnoff. I'm Terry Lohman, co-chair of UU's for Just Economic Community. And Dr. Bill is going to tell you how this is an economic issue because so much is wasted on medical care that could be preempted before it's a problem. And Bill's going to have an introduction page, so I think we'll cut right to Bill.
Thank you, Terry, very much, and appreciate the opportunity to talk with you today. So as you can see, my talk today is entitled How Electronic Medical Records Can Save Your Life and Your Money. So I wanted to put this in the context of economic injustice. And so there are a number of sources of economic injustice in healthcare. One is uneven access, the issues related to insurance, and even if you have insurance, the availability of care. And there's also the high cost, that care is unaffordable, some care is unnecessary, there are unjustified profits in healthcare. And also, most people do not have very good outcomes, and particularly in the US, we're one of the worst in terms of outcomes in the industrialized world. So the high cost and poor outcomes are driven in part by the lack of complete medical records. So that's what I'm going to be talking about today, and that's how it relates to economic injustice. Medical records, it doesn't help with insurance and availability. So fixing medical records, so the lack of available medical records kills literally tens of thousands of people and costs billions of dollars every year, and I'll have some more data on that in a minute. But the good news here is that there is a political consensus that already exists about fixing this. It's totally nonpartisan, and it's supported by current law and policy. And in particular, the 21st Century Cures Act that was passed in 2016 essentially mandates that the Secretary of HHS solve this problem. So in my view, the problem of medical records is the most important problem in healthcare with an immediate solution. Now, I'm not saying it's the most important problem, but this is a problem that we could solve right away, and I'll be explaining that. So let me say a couple of words about me. I'm one of a handful of people who are trained in both medicine and computer science. I'm adjunct professor of biomedical informatics and data science at Hopkins. And I built the first successful statewide immunization registry in the US in Oregon, and that was in the mid-90s. And then I spent 5 years at the Centers for Disease Control developing the field of public health informatics, which is the use of information technology in public health. And then I spent a few years at the US Department of Health and Human Services, organizing and leading the work that led to President George W. Bush's executive order that created a new office at HHS and was followed by over $30 billion in subsidies so that hospitals and physicians could actually acquire electronic health record systems, or EHRs. And I'm a member of First Unitarian in Portland and previously a member of All Souls in DC. So first I'm going to talk about where your medical records are, and then why does it matter? And it matters for safety and effectiveness of care, and it matters in terms of cost. And the goal here is to have complete records when and where needed. That's what we need. And I'll spend a few minutes on challenges and solutions, and then talk about some next steps. So first of all, where are your medical records? So imagine, if you will, if airplane maintenance was done without complete records. So you pull the airplane into the hangar and imagine that the aircraft mechanics only had access to the information about what has been done to that plane in that hangar only. Now, I mean, you've got to be shaking your heads or laughing. It's ridiculous. And it is. It's obviously unsafe. And in fact, if an airline did this, they would immediately be decertified by the Federal Aviation Administration. But I'm sorry to say, that's how medical records work. That's really how the system works today. So this question of where are your medical records, they're scattered. Wherever you go for care, there are records. And no one has access to their complete longitudinal records. No one. Now, records on paper can't be processed, organized, and accessed easily. Electronic records can be organized for safety and effectiveness, but they are not. Let me repeat that. They are not. So the good news is that electronic records have the potential to be organized for safety and effectiveness. This is why this is a solvable problem. So why do your medical records matter? Who cares? Well, in a very famous report, the Institute of Medicine in 1999 wrote a report called To Err is Human. And there was a follow-up study in the Journal of Patient Safety in 2013. And in that follow-up study, they estimated that as many as 400,000 preventable deaths in hospitals each year are due to medical errors. This is 4 times more than the Institute of Medicine reported in 1999. Now, it's not that they went up. They just had a better methodology for figuring this out. So we're talking about our largely outpatient adverse events and deaths, for example, from medication errors. And it turns out that preventable adverse events are the 3rd leading cause of death in the United States. Again, I want to repeat that. Preventable adverse events are the 3rd leading cause of death in the United States. And the cost of errors, at least the Institute of Medicine estimated between $17 and $29 billion a year, but that estimate is very old, and this is a huge underestimate. And other folks have estimated that up to 30% of healthcare costs are unnecessary. So what are we talking about here? So if you go to your provider and the provider thinks you need XYZ test and doesn't have access to the record of the test you had yesterday, what's the provider going to do? The provider's going to order it again. This is how we waste $1 trillion a year. So where do these medical errors come from? So, and this is another Institute of Medicine report. So one place they come from is that healthcare is increasingly complex and the knowledge is growing very rapidly, and actually no individual person can possibly know everything about healthcare and treating patients. That's been true for many, many years, and it's getting worse. There are an increased number of chronic conditions that people have. We have a very poorly organized delivery system, and we could spend an hour just talking about that. We don't use information technology effectively. But the medication errors do not come from a lack of goodwill, a lack of knowledge, a lack of effort, or a lack of resources. So what we're going to focus on for the next few minutes is the ineffective use of information technology. So what's the goal of health information technology? So as I alluded to before, the key is complete records. And this is a representation of the value of medical information versus how complete it is. And you can see that if the information is only 50% complete, essentially it's useless. And the example I would give is, imagine if there were an online system that any authorized provider could connect to that would make available half of your prescription medications. What would the usage of that system be? Well, I would argue that the usage would be 0, because half of your medications is not helpful, because I have to ask you about your medications anyway. So why would I bother going to this computer system and getting half when I can talk to you and get probably all of them? So unless the information gets to 80, 85, 90% complete, it just doesn't have much value. This is actually from a book chapter that I wrote. So the goal is to have comprehensive electronic patient information when and where needed. Wherever you go for care, all your records should immediately be available. The records have to be electronic. They are. You need to combine these multiple scattered records from all the different places you get care into a complete master record. And if you did that, you could enable rapid review of the record with graphs and charts and enhancing the relevant information given the problem that you're seeing your provider for. And you could have automated reminders to improve the quality of care and reduce errors. So the provider would be reminded, oh, it's time for this, have you checked this, and so on, based on the particular situation, if you had complete records. So I want to give you a case study illustrating the importance of this. And this is a true story. Diane, age 69, mother of a good friend of mine, was in good health and enjoying an active retirement. One weekend, she developed symptoms of a urinary tract infection. And by Sunday night, she was in so much distress that she finally called her doctor, who of course was unavailable. When she reached the on-call physician, he agreed that she had a urinary tract infection, prescribed an antibiotic. Diane, who was by then in great discomfort, immediately filled the prescription at her closest 24-hour pharmacy and began taking the medicine. And we're going to hear more about Diane's story in a few minutes. So, challenges and solutions. So, one approach to having a complete master record is what I call the distributed approach. How does that work? So, at a clinical encounter, there's a patient authorized inquiry to an index of where your records are. So we then send out secondary requests for records to these various places where you have records. So there might be a hospital record, lab record, specialists, and so on. And then those records are returned, and we put them together, we aggregate them into a temporary patient history. And we send that information back to the physician at the clinical encounter, and then that's used to take care of you. And then the encounter data is stored in the clinician's electronic health record, or EHR. And now we add a pointer in that index so that next time you go for care, that electronic health record will be queried for the information. And this is essentially a health information system. So this looks pretty good, makes a pretty picture. What's wrong with it? Well, first, it relates directly to the existing process for obtaining outside records. I'm sure you've all had this experience. You go somewhere and the provider wants to get records from your outside provider, from somewhere else. And so they call and the records are faxed. It addresses the if only this could be automated wish of providers. So providers don't like these, calling for outside records. They'd like to have the records, but what they think about is, well, I just like this to be automated. Instead of having my nurse or receptionist call and get the records faxed over, I'd like to just be able to push a button and have this happen. But this doesn't scale, and this doesn't allow searching of the records. And this is an example of automating things the wrong way. And when you automate things the wrong way, you just take the way we do things now and you just make that happen automatically instead of using information technology to solve the underlying problem. And the fact is that distributed records don't work. This kind of a system is extremely complex, wildly expensive. All the electronic health records have to be online 24/7 and respond to these outside queries. So you can imagine when a hospital or a clinic is buying their electronic record system, they have to then get a more powerful electronic health record system. So not only does it serve the needs of that hospital or that clinic, but it has to respond to all of these outside inquiries for patients that aren't even there. Not very appealing. You have to have reconciliation of records from multiple sources in real time because you're waiting there for care. And that requires a unique patient identifier. If you're going to reconcile these records in real time, you have to have a unique patient identifier. And that is first politically impractical, but it's also a tremendous threat to privacy. So we don't want to have a unique patient identifier. Turns out we don't need that. You also have to have an expensive 24/7 network operations center to monitor all the EHRs to make sure they're online, because if you go to the emergency room and your primary care physician's electronic health records not online, then your records are then inaccessible. So you have to monitor that, and if your physician's records go offline, you have to send somebody out to fix that. So it makes this just ridiculously expensive and impractical. So what's the solution? The solution is what's called a health record bank. And it's just what you think from the name, a secure community-based repository of complete health records, where access to the records is completely controlled by you, the patient, or whoever you designate. These are essentially electronic safe deposit boxes. Information about your care is deposited once when it's created. And by the way, this is required under HIPAA, the Health Insurance Portability and Accountability Act. The P in HIPAA, by the way, is not for privacy. That's another discussion. This system allows incentives to physicians to deposit the electronic records. So you essentially pay them to make these deposits, which is helpful in getting it actually done. The operation is very simple and inexpensive.
Imagine you or someone you care for is rushed to the emergency room and might even be unconscious. Without important medical history, lives may be in danger. Does the emergency room doctor have all of your up-to-date personal health information? Do you? How can you or your doctor get it immediately? If you're like most people, your medical records aren't readily available to you or any doctor. Today, wherever you seek care, a record is left behind. A record you and your other doctors can't immediately access. Until now, no institution has been available to automatically receive and securely store your records and make them easily available when and where you need them. Now there's a way with health record banks, a secure approach to storage where you alone control access to your health information. Think of it like a digital safe deposit box. When seeking care or in an emergency, you authorize an information withdrawal, giving your doctor access to some or all of your records. When care is complete, new records are deposited, and the information can be used to automatically complete time-consuming forms. Health record banks make good sense. You alone control who accesses your personal, private health records. Records are stored in one location and automatically updated when you receive care, anywhere in the world. Your information is safeguarded by the most secure data protection and encryption methods. And with multiple banks available, the choice is yours. Take control of your health records today. This message brought to you by the nonprofit Health Record Banking Alliance, promoting and supporting the development of health record banks.
So I hope that video was helpful in explaining the concept. Looking at the details of the operation, the Health Record Bank has secure patient health data files. And then in a clinical encounter, the clinician will inquire for your records. And if you give permission, if you don't give permission, nothing is done. If you do give permission, then your records are sent. Again, the encounter data is stored in the clinician's EHR. The new data that's generated is sent one time to the health record bank, and optionally, the bank can make a financial payment to the clinician as a reimbursement for depositing the records in the bank. So it's much simpler, much easier to operate. So the rationale for this is, as I said, it's operationally simple. The records are immediately available. You deposit new records when they're created. It enables various value-added services, and I'll talk about a couple of those in a minute. It enables research queries. I mean, all of us want medical research to be done. We want to be able to give permission for our records to be used for research, but we're all interested in generating more knowledge, particularly about diseases that we have or our family has. The patient control of the records promotes trust and privacy. And also, because you are in control of the records and you are making the requests, all the stakeholders who have records are required to cooperate under HIPAA. The low cost of this facilitates a number of business models, and I'll show you an example of one in a minute. It aligns incentives by paying for deposits. And let me show you how the health record banks create value. So you start with the health record bank, including payment for deposits to physicians. You get more complete electronic health record information. This enables physicians to provide better patient care. And patients sign up for health record bank accounts recommended by physicians. I mean, physicians want to have your records so that they can take care of you. They don't want to be surprised about medications that you're on or procedures that you have, or and so on. This enables delivery of optional services with compelling value, and those optional services can generate the funds that actually pay for a health record bank. So here's an example of a health record bank business model. So first of all, the cost. So if you assume there are 1 million subscribers, operating a health record bank would cost about $6 per person per year. It's relatively inexpensive. Those deposit incentives would cost about $10 per person per year. So the cost is about $16 per person per year. Now, let me say, I'm going to show you kind of a for-profit fee-for-service model, business model for a health record bank. But you could also say, well, gee, $16 a year in the context of healthcare costs, which average $10,000 per person in the United States. $16 a year doesn't seem much to spend. Maybe we should just pay for that and make it free to everybody. That's okay. That's a perfectly valid business model, and I certainly would support that. But here's a service delivery model. So you can generate revenue, first of all, by advertising. You could generate probably about $3 per person per year, or you could ask people to pay a fee to get no advertising. But the main source of revenue, in my view, could be what reminders and alerts. And let me give you, and so I estimate that you could generate $18 per person per year. And this assumes only 30% penetration of reminders and alerts costing a total of $60 a year. So there are 3 of them that I'll give you examples of. First, and I think most compelling, are the peace of mind alerts. And what this is if your records are accessed by an emergency physician, meaning you're in an emergency department somewhere, a predefined list of your loved ones would immediately be notified electronically that you're in the emergency room. Everybody really wants that. I think that would be very valuable. Many of you have probably had the experience of finding out way too late about some loved one who's in the emergency room. And you might say, but the emergency room will call me when that happens. Yes, they will. But are they going to call you first, or are they going to access the person's electronic records? Of course, they're going to access the records first. Second, preventive care reminders. So actually, this should be paid by insurance. So this would remind you to get your flu shot, to get your eyes checked annually, get your annual physical, etc. And the beauty of this is that these are what I call smart reminders because it's tied to your records. When you do the thing that you're reminded to do, it doesn't remind you anymore. It will say, thank you for doing that. So you don't get ridiculous reminders of things you've already done. And then finally, medication refill reminders. Now, of course, pharmacies provide those, but this would be independent of pharmacy. You would get, say, a text message saying, time to refill your Lipitor, text back the letter Y if you want us to do that. And you just respond and then it's taken care of. This would increase medication compliance as well, which would be wonderful. So if each of these is priced about $20 a year, which is pretty modest, and there's 30% overall uptake of this, that generates an average of $18 per person per year. So I'm not assuming everybody essentially selects all of this. Finally, there are queries into the database. There's for research and for public policy, and there are many organizations, and of course, they would have to prove that they're legitimate and using the data for a reasonable purpose. But there are many organizations that would want to query the data, again, with your permission, and you could generate some additional revenue from that. So my estimate here is about $24 of revenue could be generated by a health record bank. But you notice that nowhere in here did I say anything about saving money in the healthcare system. And this business model actually does not assume or try to capture any healthcare cost savings. Whatever the savings are, go to whoever saves the money. So this is why, because of the low cost of health record banks, there are lots of different ways you can fund this from a business perspective. Now, there is a security challenge, which you may be thinking about, which is we know that centralized data is the best way to ensure security. And the reference I give here is from 1976. It's really old. This is not new. And the reason for that is that distributed data is less secure because it has to be sent multiple times for each use. And in fact, for example, the Department of Defense has a manual for creating electronic databases. And the first thing it says is all the data has to be in one place. So, but there's an inherent vulnerability of a central database because you have a single point of access to all the data. And so potentially, if some unauthorized person gets in there, you could lose all the complete health records in an entire community in one incident. And that is absolutely unacceptable. In fact, it's so unacceptable that if there's any risk of that, I would argue that means you can't build the system. It's too dangerous. So now we've all heard about multiple security breaches of all kinds of systems, and there's a widespread belief that no system is secure, which isn't really true, but that's the current perception. So the key here is, how can you have efficient searching of a system like this without a central database? And there's a solution. So the way you can avoid total data loss in a healthcare repository is to have each patient's data stored in a central location, but essentially you have a separate database for each patient. Each patient's data is in a separate file, separately encrypted. And so what that means is there's no single point of access to all the data. Even if an adversary were to physically take your server away, they would have to work extremely hard to decrypt one record, and then they wouldn't know anything about the other records. And this is, with current computer technology, this is beyond the capability even of the National Security Agency. The problem is that there's a reason we put records in a database, and that's so we can search the records easily. And as I mentioned, searching is important for research and for public policy. So how do we do that? So when you search records that are stored and encrypted separately, it goes like this. So you get the first record, and then you decrypt it, and then you look for it, and then you go get the next record, and you loop around. And so this requires, if you have N records, say 1 million, you have to go through this 1 million times. Everything we do in computer science about databases is designed to prevent this from being necessary because it's so slow. So, but what if we had 2 processors searching at the same time? Then we could retrieve 2 records at once. And now we only have half the number of times through this loop. And you can guess where I'm going with this. What if you have some arbitrary number of processors, K? Then you can retrieve K records at a time. And this requires 1 million, say, divided by K iterations. And in today's cloud computing environments, K can be 1,000 or even 10,000. So you can go to a cloud computing provider and say, I'd like 1,000 servers for the next, half hour. And you can get your 1,000 servers, run your search, and it can be very fast. So this idea of secure repositories of health records is called the personal health grid, where each patient's record is stored in a separate database with separate encryption. And you can efficiently search this with massively parallel searching using virtual processors in the cloud and or network. So another way you could search this is if people had their records on their mobile phones, you could send the query to the mobile phone, and each mobile phone would search its own record and return the result. And essentially, you could search an infinite number of records in the time it took for one mobile phone to search the biggest record. There's no access point for all of the patient's data, even for the operator of the service. So even whoever is running this service can't access all the data all at once. And so this essentially eliminates this database in the sky security vulnerability. So it is just not possible to lose all the data all at once. Now, that doesn't mean it's not possible to lose some data sometime, somewhere. No system is perfectly secure, but you can't lose all the data all at once. So this brings me back to Diane. So you remember in our last episode, she started taking her medicine for her UTI, or urinary tract infection, and instead of feeling better, she got worse and worse. Finally, she lost consciousness, and her husband took her to the emergency room in the middle of the night, and she was admitted to the hospital. She spent nearly 2 weeks there, suffering from multiple organ failure with one complication after another. And in the end, the doctors were not able to save her. Turned out that the original antibiotic that was prescribed for her urinary tract infection contained sulfa, which she was allergic to. The on-call doctor had no records reflecting this known allergy. And remember, this is a true story, and I do have permission to tell you this story. Diane's husband and 4 children were devastated. With a unified health record, she would have gotten the correct prescription, and she would be alive today to enjoy her grandchildren. So, next steps. What should be done? What can we do about this? So we need to pilot a health record bank in a community somewhere. It needs $10 or $15 million to build. Could be either government or private investment. And of course, $10 to $15 million is a lot of money, but in the context of healthcare, it isn't. We can demonstrate this effective solution. And by the way, this is running in a number of foreign countries like Finland already, so you can look and see that this works. And this can reduce healthcare costs 8% or more, which is 8% is a massive amount of money. We're talking hundreds of billions of dollars a year. And it doesn't take anything away from anyone. And it improves the quality of care. So I'm happy to, that's all I have to present, and I'm happy to answer any questions. And I will